You've been already doing well with the scans that you've been receiving, and and the reason for using AI was to further enhance that experience to your end customer or to the patients. So obviously, adopting AI, and especially if I were to talk about QER, was a very crucial decision. And how Medica has done is, like Sam was saying a while ago, multiple phases of evaluation, ensuring that the performance is actually in terms of accuracy, in terms of turnaround time, in terms of the way scans are being processed, everything. But apart from this, so while that we could do, we did all of that. But apart from this, there is this huge component of when two technologies marry each other, the engineering component. Both parties, we had to go through a lot of engineering, and it's totally okay because that's only the way that both of these would be tightly coupled to each other, and we will get the desired results. But all of this happened during the pandemic. We did everything remotely. Everything in terms of what our requirements were, what we need to do, how the two teams need to communicate, build, operate within the data privacy constraints, the compliance, everything. We did it remotely. During this process, to hear from you, while we were doing all of this remotely, what were your considerations? What were your thoughts before we started doing this? And most importantly, how do you think it panned out?
I think when we look back now on all of the things that we've been able to do under the constraints of a pandemic, I think that we are really quite amazed at what we have been able to achieve. And in fact, I think certain things that we've done have actually been done better because of the technology we've been able to adopt. And I think that's one of the key learning from the pandemic is that sometimes it is actually better to have the sort of flexibility that we've been able to have because of using this type of technology for remote working, rather than assuming that we've got to bring people together into a room and we all have to be geographically co-located. So I think that's really a very positive piece of learning. I think the other thing to say is that when we started working with you in anger, as it were, we'd already been working remotely for several months. The here in the UK, our lockdown began in March, and so we'd sort of got ourselves up to speed relatively quickly with the fact that we were absolutely constrained. We had to remain in our own houses. We had to use this sort of technology. We had to be far more, I think, efficient in our communications. We couldn't really allow the sort of ambiguity that you can allow if you're sort of sitting in the same room as somebody. You can sort of gauge body language far more efficiently, I think, if you're in a meeting than you can if you're seeing 15 small faces on a Teams screen. So I think that meant that we knew that we needed to have very clear, very transparent communication. I think the other thing is that the way that we'd planned the project, and we'd planned the project before we knew we were going to go into lockdown. So David and I had spent quite a lot of time thinking through how we were going to do the proof of concept, what our success criteria were, and how were we going to measure the success of the project, who we needed from a Medica side to be involved in the project, sort of what skills, capabilities, resources we actually needed. And I think the one thing that was, we work on a number of projects, and one of the things that from the first, when we started working with Qure, was there was such a difference in that you were always responsive. If there was an issue, we worked in partnership. There was never you going, oh no, that can't be us. It was always, okay, how can we work together to try to find a solution? And then the artifacts one was, that David mentioned, at the beginning, we started our proof of concept, and we found that there were a number of scans going through that were identifying, false positives because of artifacts. So it was Qure who said, well, actually, we've got something that can help with that. Let's build this additional algorithm in. And I think it was an absolute breath of fresh air to us to be working with a partner who genuinely entered into a real spirit of partnership across the project. And that sense, I think, we are all doing this with an inquiring mind, with a desire to improve our knowledge, with a desire to improve service, with a desire to sort of really innovate in technology. And there was never, I think, a single occasion when it was anything other than, I think, a really open and transparent relationship. And one of the things, we're not just remote, we're operating with sort of quite significant time differences. And again, we've been incredibly conscious of the fact that sometimes, you'll have been working sort of for hours, and it's sort of early evening or even later on in the evening, but you're still there sort of on the platform, you're still working with our infrastructure guys to try to resolve any of the problems that have come through, and that's absolutely awesome. I think the other thing is, what's interesting about implementing or for QER, and I think it probably will be the same for any other algorithm, is almost, you can say, the quality of the algorithm is a given, because you're not going to implement it into a production workflow if it isn't. The challenges are around that implementation. They are around how we get this sort of very diverse and, in our case, quite bespoke architecture of a complex range of components to then be adapted to involve also the algorithm. And I think that for us is probably one of the biggest pieces of learning, that is really where the challenge lies, because our assumption is that the algorithm itself, having gone through the rigors of testing, having gone through everything that it's needed to have to be registered as a medical device that we can use, that's where the challenge lies. And I don't think that we'd really appreciated that at the beginning of the project. So, yeah.
I think you're right. We've learned so much about how to implement an AI tool. All pretty much all the documentation that I've seen, all the papers and the reports and the news articles that you see on AI, is all about ROCs and the quality of the actual algorithm, and it's nothing about the difficulty of getting your DICOM images off your packs quickly enough to fit into your workflow. It's not about the issues you might face in terms of taking your HL7 or your JSON responses and making them available to the right people at the right time. And we certainly learned that, and I think that it's something that we have benefited from, to be honest. But going back to something that Sam was saying about how responsive you guys have been, I think one of the really telling things you can say is that it doesn't feel like there's a 4.5 hour time difference between us and you guys. And it's the number of times that I've had to say to Sam on, say, a Tuesday morning, so Shank got in touch with me last night at 6 o'clock. I think that was probably about 10:30, 11 o'clock at night for him. So yeah, it's been absolutely fantastic working with you guys on that.
That's really great to hear. Two points here. One is that so nice to hear this, very rewarding, and all thanks to our engineering, all the people behind the scenes, right? Very little spoken about them. All thanks to them. You actually brought up a very important point, right? We hear about AI. AI is new, but then now that there is a lot of evidences, there is a lot that is established, a lot of real world validations done. You hear about it everywhere. Like you mentioned, everybody speak about what is the ROC, what is the AUC, what is the sensitivity, specificity. Too little is spoken about how is AI actually implemented in a workflow, in a radiology workflow, or in a clinical setting. Too little, and then AI is new and it will have its own challenges, and it's fine, and that is what we need to discuss. I think there should be communities to discuss more about that. There are already communities, but we need to have more and more discussions like this. So thank you for bringing that point up. So we have, when we look at QER and Medica, right? We see three stakeholders or three points that we always consider. One is Medica as an organization. What does Medica want to achieve from using Qure, which was pretty much clear as well when you were talking about Medica's goals, etc. The second is the reporters in itself, the radiologists, the different specialists who are consuming these results. And the third is the clinics, who are not directly interacting with Qure's product or Qure, but they are also in a way affected in terms of improvement in turnaround time and all of that. What can you share some thoughts around or shed some light on what has changed before and after introduction of Qure? If you can talk about all three different stakeholders, great, like Medica as an organization for the end users and the clinics, but at least if you can just give some idea on what has been the change after getting Qure on board.
Yeah, sure. I think that Qure has been a massively valuable tool for us, and it's because of the sheer volume of exams that we need to report for Nighthawk. During our busiest hours, we might receive 4 or 5 CT head scans in the space of a couple of minutes. Historically, pre-implementing Qure, we'd allocate those scans out first in, first out, essentially. We'd have some prioritization in the, if a client's notified us that it's a query stroke, it's on the stroke pathway or what have you, then yeah, there'll be some prioritization there. But essentially, the majority of the allocation is first in, first out. Now that we've got the Qure algorithm in place, it can evaluate, those 5 scans that have come in that 5 head scans that have come in that particular period, and it'll let us know whether one or more of those is suspected as having a ICH. If it does, we can then prioritize allocating that particular scan to the next available radiologist, rather than wait until it gets to the top of the first in, first out kind of queue, if you like. So I think that all of the stakeholders that you mentioned benefit from that Qure being in place. We benefit, Medica, because we can provide an ever-improving service to our clients, knowing that we can allocate out those studies where there's prioritize the allocation of those studies where there's reason to do so is great. Our clients certainly benefit, and our patients benefit. Obviously, if you're prioritizing those scans where there's a indication or a suspicion that there's an ICH on the scan. And our radiologists also benefit from this, because it all comes down to that prioritization. Is a prioritization tool for us at the end of the day. And our radiologists, they also want to prioritize those scans that have got more clinical urgency associated with them. And they can do that because we provide them the information that they need that's come out of Qure to show them that the algorithm has picked up on this suspected ICH. So yeah, I think all three benefit, and what they're all benefiting from essentially is the same thing: the fact that we can prioritize the allocation of the scans where there is a suspected finding, and the reporters can then prioritize the reporting of that scan, knowing that the algorithm has picked up on that suspected finding. And all of that adds together to us providing a better service to the client, if you like, and to the patients, through the fact that the more urgent scans are being looked at first.
Yeah. Sam, do you have anything to add? Or
no, I think that's completely agree with what David says.
Great to hear that. I think what, and you might agree with me on this, what defines the success of a product is not its accuracy. Accuracy is, of course, one major factor, accuracy, the engineering that goes into it, but also how, how it interacts with the user, the usability factor, how is the software or the product in itself is adopted, and generally the clientele and the confidence for your end users in using that solution. Right? There are multiple factors in consideration that actually defines the success of a product. Could you shed some light on what has been some of the feedback that you have received from the end users? Because some clinical feedback, right, from the reporters across all of these different aspects, or some of these aspects, if you can.
Yes, and this is one of the things that we've been sort of very, very mindful of, and for us, engaging with our reporter community is hugely important. As David said, we've got probably between 500 and 600 reporters now across the globe, and our ability to provide the sort of levels of service we wish to provide and hope to continue to provide to our clients is entirely driven by the quality of our reporters. And so all the way through, we worked with, in the first instance, a small cadre of reporters who we used on the proof of concept, so that we were getting their feedback both on the accuracy of the algorithm, but also on how it was positioned within the workflow and the way that they would wish to see it being used in full adoption. And then post go live, we went live on the 7th of December last year, moved Qure into our production environment. We've also carried out a number of exercises with our reporters, and we also have provided them with a tool that enables them to respond to anything they see in the algorithm in a completely proactive way. So if they see something, we've got one which says great spot, so if the algorithm identifies something which the reporter thinks, yeah, that was brilliant, I wouldn't possibly have noticed that had the output not been there. But it also allows them to provide any information if they're querying something, or if they believe that there's been a false positive. So we collect that data with every single study that goes out. And we've also done a number of pieces of feedback from reporters as part of our formal evaluation of the algorithm. And that's something that we'll be doing going forwards. So from that, I mean, we've had some very, very encouraging feedback. So sort of 81% of those reporters who've actually fed back to us, which is quite a high proportion, say that, yes, they agree with the findings, and they've got sort of trust in the algorithm as a result. And 71% of those who have used the algorithm say that they've found it helpful in terms of both prioritization and also reporting. So that's I think a very, very positive, given that this is information that's been gathered from our early adopters. It's still very, very new to the workflow. It's still very, very new within the teleradiology community. Some of the things that, some of the comments I've got, I'm just going to read some examples. The algorithm is excellent, highly likely to reduce the chances of missing a small amount of intracranial hemorrhage. Very good on the whole, comes into its own for the smaller bleeds that can be easily missed. And it's very useful in identifying patients to get higher priority in reporting promptly. So I think there's very much a sense of a recognition from our reporting community that they are finding it a positive benefit, and that one of the things that we've been really encouraged by is, I think, a welcoming from our reporter community to adopt AI as a support to their reporting work. I mean, clearly it is the doctor who reports, and it's the doctor whose clinical expertise determines what goes into that report. But to have that prioritization there has been very helpful to them. However, as again one of our reporters has commented quite rightly, it's still an evolving process. The software itself, the algorithm is still evolving, and our use of AI is still evolving. But the work that we have done with our reporter community, and the work that we'll continue to do, working very, very closely and making sure that we're providing an environment for reporters where they wish to work with and for Medica, and they see that Medica is supporting them by providing them with the reporting tools that enable them to be their best. That relationship will continue ongoing. We plan to do another evaluation probably towards the end of June, because some of the work that David and our infrastructure team and Qure's engineers have been doing to speed up even further the speed of the process is just about to go into our production environment. And sort of once again, once that has happened, we want to get even more feedback, because it's really important for us that we never sit on our laurels. We are always trying to make improvements to that environment, and our reporters are, I think, very, very engaged with that, and are delighted to support us in what we're doing, working with Qure and Qure.
While you were saying these, you were reading out some of this feedback, right? This is what I really like about working with Medica. Some of the points that you brought up, that you can either say this is working and then leave it at it. Oh, one radiologist or a few radiologists, 81% said great, and we leave it at it. Or we say, oh, there is some set which is not working for them. But the evaluation, the evolution, you and us, we believe in that. And it is continuous, right? You're already talking about a next evaluation that we are going to do based on some of the engineering changes that we are doing, some of the optimization that we have already done. So this is really encouraging. I think everybody should understand, everybody not just in the radiology community, the hospitals should understand that it's an evolving process. And thank you so much for bringing that up. So do you think, you've shared a lot of your experience, right? Based on your experience, based on what you have seen, of course, there has been challenges, there has been, working all remotely, all of this. But based on your experience working with Qure or generally across other innovations, do you think teleradiology companies should bring in more innovation in their ecosystem, in their setting? What would be your take on that?
I think all companies in all settings should be looking to be innovative. I don't think teleradiology is any different. One of our core values at Medica is that we're adaptive and pioneering, and we do look for opportunities to adapt our processes and implement new technology to help ensure that we're providing the highest quality service to our customers and patients that we can. We demonstrate our innovative nature every day. The fact that, as I said earlier, we have our own software development team building our own in-house systems that that designed to fit our bespoke workflows, is supplementing our PACS technology and the other off-the-shelf systems that we use, where we find that we can't procure something that we need to meet our needs. Don't bend an off-the-shelf system, or don't bend our processes to fit an off-the-shelf system when you've got you got the resource and the skills to design and build your own. The fact that we've worked with you guys to implement the Qure algorithm, and we've got the wider Future Tech program underway, which is a really exciting set of projects, all of which are essentially examples of Medica being innovative to make improvements, because we do see it as being important. As Sam said, we don't want to rest on our laurels. We provide a great service, but we don't want to just sit on it and let it get stale and not improve it where we can, when we can always look to innovate through process redesign as well as implementing new technology. And I think all teleradiology companies should really have the same kind of approach and mindset.
Great. No, thank you very much for sharing that, David. Very insightful conversation, I would say. Anything else that you want to share? Not necessarily about Qure or positives about experience with Qure, but generally across anything that you want to share for the audience, for the listeners, because when you adopt AI, it's sometimes we have seen this some form of a hesitance because they do not know how it works in their environment, right? I really hope that whatever you have shared today, would help them to help some of these organizations who are thinking about adopting innovations, who are in the process of adopting innovations, and in now or in future. So thank you very much for that. Anything else that you want to share with us?
I think the one thing I would sort of urge anybody who wishes to look to this sort of project is to really think clearly about what benefits they wish to achieve from it. Why are they choosing to do this? Because if the benefit is you want to do this because you think it's going to improve your share price, the way that you respond to it will be very different from if the benefit is because you want to improve your processes and make your processes more efficient. If the benefit is because you wish to streamline your organization, again, the way you'd evaluate that is very different. If the benefit is about improving sort of clinical rigor. So I think it's really important to be clear about why you're doing it, and also to be clear about then how you will evaluate those benefits. And I would definitely say you need to have a proof of concept which is sort of rigorously in place and rigorously assessed, because I think one of our pieces of learning is about the need for investment in change to the way our processes run and the way our workflow runs. And if the organization thinks that adopting an algorithm is simply plug and play, you just buy it off the shelf and plug it in, then they're going to be sort of quite surprised, and they need to understand the wider scope of the project before beginning it. So that would be my advice.
Yeah, my advice would be, to follow on from what you're saying there, Sam, is you need to engage all the relevant people from within your organization. It's not just the end users, if you like, the radiologists who you need to pull into this. You've said a number of times how great it's been working with the team at Qure to deploy the Qure.ai solution, but also working with our own team. We've had a project team for the AI project, which includes infrastructure, software development, clinical governance, radiologist liaison, service delivery. We pulled people in from across, as well as Sam and myself from the project and future tech perspective. We pulled people in from across the organization because we recognized very early on that the impact of implementing an algorithm like this or an AI solution will impact on so many parts of the organization, because it impacts on the whole process, the whole workflow, and it's been a really it's been a pleasurable project. It's been a great piece of work when you've pulled all those people in and you've got them enthused and they're all really keen to make it work. Got you guys at the other end equally enthused and really keen to make it work, and it's been great. The fact that we've had to engage all of those staff and bring them in and really put a lot of resource into deploying the solution just by including all of these people shows how important it is to do your planning and to recognize the fact that it isn't just that plug and play kind of solution. As Sam says, it's far from being just plug and play. Very little is plug and play nowadays unless you're plugging a headphone in to talk to someone on a conference call. So I just engage the right people, pull them all in at the beginning, help them design and build the solution with you and the processes with you. That'll be my tip of the day.
Amazing. Totally agree with you, the points that you have brought up. And I personally had a lot of learnings with Medica in terms of the processes, the way in which you implement the processes, the engineering, some of these aspects that you said that involve the right people. You first establish what your goals are, measure them throughout the project period. That's totally some of the learnings that we've had, and I hope now it is something that the listeners can also learn more about. Thank you very much, both of you. Thanks a lot for spending your time. We really look forward to working with you more closely and really making this a huge success. Thank you very much.